pressure while getting propofol every 5 minutes at least. And that was not done.
There's more equipment that's required.
Yes, okay. The next thing you need is an EKG monitor, so we can monitor your heart rhythm, make sure no bad arrhythmias occur. He did not have an EKG monitor.
And how does the EKG monitor work?
You put electrodes on the chest, and then we can see how the heart rhythm is on a screen. So if there was a normal rhythm, you could see it, and if there is extra heartbeat, sometimes that can be an early sign of irritability. And when the patient starts to get low oxygen, the heart starts to be stressed, you can start having arrhythmias. And so you want to have a monitor in order to monitor arrhythmias.
In addition to the blood pressure, the pulse oximeter, and the EKG,
yes.
What additional equipment?
You need oxygen, and he did have an oxygen. I don't know the exact oxygen supply he had, but you should have various types like nasal cannula through the nose or a mask. You need suction, because as I told you, you can regurgitate things into your mouth. Suction is what you see at the dentist when he sucks out your saliva. You want to have that so in case someone regurgitates, the nurse can quickly go in there and suction out these things from your stomach before it goes into your lungs. The other things you need is a bag mask or an ambo bag, and you need to know how to use it. An ambo bag is a oxygen mask. It's connected with a valve and a large air chamber that looks like a football. And what happens is you can give positive pressure oxygen, meaning you put the mask on and you can push oxygen into someone's lungs. Dr. Murray had an ambo bag, but he did not use it.
And you're taking that from his own statements where he states that he did mouth-to-mouth on the patient but makes no mention of using the ambo bag.
Yes. He gave mouth-to-mouth, and he did not use the ambo bag, but on a picture I saw that there was an ambo bag on the floor. Okay. The next thing, which is probably the most important, is a way to summon for help. When we give sedation or do a procedure, we either have a nurse that we can have call the rapid response team or the code team, or we have a button that we just press and the cavalry comes over to help us.
What do you mean by the cavalry?
Well, usually it's multiple nurses, a respiratory technician, sometimes an anesthesiologist, or a emergency room doctor who's adept at fixing someone's airway and intubating the patient.
And any other required equipment for this area that you're talking about, the monitoring?
Well, one documentation we'll talk a little bit later. You need a good room with nice lighting. You need a backboard. Everyone has a backboard. That is a hard surface board that we can put underneath the patient. God forbid the patient has an arrest and we need to give CPR. The patient's usually on a soft bed. And when we give CPR, we have to push down with our two hands 2 inches down their chest. And if we do it on a soft bed, we're just going to displace the patient down 2 inches. So we put a backboard underneath them in order prior to doing CPR. The other things you need is a backup battery. In Ventura County, we had a blackout about a month ago. I know there was one in San Diego. God forbid you're sedating someone and the lights go out, you should have a backup generator.
And that would be for the various equipment you've described?
Absolutely, the pulse oximeter, the automated blood pressure cuff, because if the lights go out and your patient becomes hypoxic, you may not know what's going on. God forbid they have an arrhythmia, you don't have an EKG monitor, you can't defibrillate them because the defibrillator will not be on. The other things you need, the other things you need is an oral pharyngeal airway. I told you how sometimes the tongue can slip back and obstruct the airway. It's a little device that keeps the airway open. And then very important, it's utmost importance, you need equipment to rescue the airway. like a tube to put down people's throat into their trachea and lungs, just in case someone stops breathing and you used a bag mask and it doesn't help, we need to be ready to intubate the patient. So you need to have that nearby.
And that's an endotracheal tube?
Endotracheal tube, yes, sir.
And that would also, when you're administering propofol, you would have to have someone trained to also be there to manage the endotracheal tube and get it put into the patient, essentially.
Yes. Yeah. We use, I mean, again, we only use mild or moderate sedation when we're a cardiologist. But sometimes in the procedure, the patient can get over-sedated. They usually don't. Over-sedated, there's equipment is still in the room, and an anesthesiologist or emergency room doctor with a press of the button can come over within a minute or two and intubate the patient.
And Dr. Steinberg, you indicated they can become over-sedated. Usually not, but they can. That's a foreseeable, likely consequence.
Absolutely.
And that's this continuum where a patient can actually cross from, for example, light sedation or into moderate sedation, and you can pass from moderate sedation into deep sedation, and that's one of the dangers and risks that you need to be prepared for, correct?
Yes, sir. And absolutely. With propofol, I understand it has a very narrow therapeutic threshold, meaning you can go from one edge to other quickly.
In addition, then, you mentioned the airway management equipment and the endotracheal tube. Any other equipment?
As I said before, there's a defibrillator. That's a special machine that we shock people's heart back to normal. There should be a defibrillator, and it should be on, ready to use. The other thing is you need a lot of special drugs when we're giving sedation. He had one of them called flumazenil, which is a reversal agent for benzodiazepines. That means it's an antidote to benzos. Those are one of the required ones. The other ones are Narcan that reverses narcotics. If someone has an arrhythmia, we should have amiodarone, lidocaine, beta blockers that can stabilize the rhythm. If the heart rhythm is too slow, we should have atropine to increase the heart rate. If the blood pressure is too low, we should have medications like dopamine and epinephrine in order to increase the blood pressure. If there's an allergic reaction, we should have prednisone. If the sugar is low, we should have dextrose.
Anything else as far as the typical required standard of care equipment?
Very important. When you're giving sedation, you should have an assistant to help you who's ACLS and BLS certified, meaning that when you're giving sedation, things can happen. You can't always monitor somebody, and there may be a lot of things to do. You should have someone there who's trained to know what to do.
Let me ask you before you said ACLS and BLS certified.
Yes.
What is BLS?
Sorry. BLS is basic life support. That's the basic course you guys take for cardiopulmonary resuscitation, CPR. You learn mouth-to-mouth skills, how to do chest compressions. ACLS is more advanced life support, or advanced cardiac life support. Those are things we usually do in the hospital. They deal with, putting an airway in somebody, IVs, different heart rhythms, different conditions that can happen, different arrests, different medications we give. It's a little bit more advanced.
And that person, someone trained in both BLS and ACLS, is part of the staffing requirements to safely administer propofol.
Yes.
And again, in one heading, you talked about the equipment as well as the staffing, but again, both of these would be independent, individual, extreme deviations?
Yes.
Now, you went on to describe a third extreme departure or third finding of gross negligence, and that was inadequate preparation for complications or emergency.
Yes, sir.
Can you describe your findings in that regard?
Yes, sir. It goes a little bit with the equipment and monitoring. When you have all this equipment, you need to be prepared to use it. You need to be prepared to call for an emergency. You need to be prepared to have the flumazenil ready to inject it in case of a problem. You need to know how to use, there was a bag mask there, an amber bag. You need to be prepared to use it. If someone's not breathing, you need to be prepared to intubate somebody. If you have a low blood pressure, you actually have to have a monitor and the medications potentially ready to give it to them. And if in case of emergency, you should have a person there ready to call for help or assist you. Those are examples of things that he was not prepared to do.
And the next finding of extreme or gross negligence you noted was improper care during the arrest.
Yes, sir.
First, what do you mean by during the arrest?
An arrest is when something stops. In Mr. Jackson's case, it was his breathing. So when he was trying to resuscitate and help Mr. Jackson, he didn't follow appropriate protocol.
And can you describe, again, as a cardiologist, when there is an arrest situation and there is respiratory depression, that will then lead to cardiovascular depression or failure?
It can. Can I explain an arrest a little bit?
Please.
Okay. I'm going to explain very briefly.
Your Honor, there's no question. The objection sustained.
Would you
A
please,
question and then an answer.
would you please explain what an arrest is, Dr. Steinberg?
Yes. I'm going to explain briefly a cardiac arrest and then Mr. Jackson's respiratory arrest. A cardiac arrest is what you normally know as a heart arrest, is that the heart stops beating. Essentially, you go into an arrhythmia, likely due to a structural problem or a heart attack. The heart just goes into an arrhythmia called ventricular fibrillation, and it doesn't contract. When it doesn't contract, there's no blood pressure and no blood moved. So the patient collapses, or you find the patient down. When you see that, that's most likely a cardiac arrest. So the most important thing is to get a defibrillator because you want to shock that person back. So when you see that, you got to call 911 and tell someone to get a defibrillator, and then you go down and start doing chest compressions or CPR. When we do CPR, we're trained to have someone on a flat surface, and we use two hands and we go down 2 inches. What happens is this is the heart, and when we press down, we increase the pressure in the lungs and push down in the heart, and that pushes the blood forward. When we release, the heart fills up with blood, and then we push down, and the heart flows forward. So that keeps the blood circulating, waiting for the defibrillator. That's a cardiac arrest. And a respiratory arrest, like Mr. Jackson had, he stopped breathing. There's still oxygen in the lungs, though. And so the oxygen slowly goes down, but the heart is beating fine. It's normal. But when the oxygen gets lower and lower, the heart realizes it and the brain realizes it, and it starts to get excited. It starts to beat harder and stronger because it needs to circulate the lower density of oxygen in the blood system. This is approximately where Dr. Murray found Mr. Jackson.
And again, you're basing that on Dr. Murray's words?
Yes, because I'll expand. But
We'll have a question, please.
No, so you were indicating then at that time, this is where you're describing how the heart's reacting to the respiratory failure.
yes, sir.
And then, please elaborate. You stated that this is where Dr. Murray found Mr. Jackson?
Yes, but I want to. What happens if you don't do nothing is, and what happened also with Mr.
If you do nothing?
Let's say, and naturally, let's say there's no one there. What slowly happens is the heart starts to weaken because the heart is muscle and it needs oxygen to work. So when it stops getting oxygen, it just stops working. But the electricity is still going, but the heart's not contracting. That's something called pulseless electrical activity, meaning